first of all, I'll clarify who I am and what I know about fibromyalgia. I am a physical therapist. I have worked with a lot of clients who have fibromyalgia, both in the context of physical therapy and in Pilates. And I actually had the privilege of working in the same office with Melissa Congdon, who's coming to speak to us today, as she was developing her fibromyalgia practice. So I can share her bio with you, but basically her story is that she was a pediatrician. That's actually how I met her. She was my children's pediatrician for 18 years, and she herself became very ill, was diagnosed with fibromyalgia, and then went and sought out her own treatment. She had to stop working entirely. And I had the privilege of watching her go from being completely ill into coming back to life and being a practitioner, at which time she chose to be a specialist in fibromyalgia. So that is how I know her. And so I've known her for quite some time now. And I've had the privilege of working with a lot of her patients as well as other patients who are not hers in fibromyalgia. So oh, here we go. She's coming. Yay. Okay, so I won't have to tell you about it. Hi.
Hi.
Hi, welcome. I was starting to give a little bit of information from your bio. Melissa, this is Melissa Congdon in the flesh. And so I'm going to continue on that road. Just one moment here. Okay, so let me give you a little bit more full bio. So I had mentioned that you were a pediatrician, Melissa, already, that you had symptoms of fibromyalgia, and then to get yourself healthy again and open your practice that you're now specializing in, she was using a combination of diet, exercise, acupuncture, supplements, medication, and the gliflozin protocol, as well as other modalities, and able to return to her medical practice in 2009. And then she became a fibromyalgia consultant, training with fibromyalgia expert Dr. Paul Saint-Amand, who's an internist, endocrinologist, and associate professor at the Harbor UCLA Medical Center. So then, as I mentioned before, since 2009, Dr. Congdon's been working and specializing in fibromyalgia. She's treated over 800 children and adults with fibromyalgia. She finds fibromyalgia a super fascinating illness that can cause a number of severe symptoms. Happily, a lot of these symptoms are very treatable, improving the patient's quality of life. She's delivered keynote addresses at the Hawaii and Colorado Springs Fibromyalgia Summits and produced a documentary that's available on her YouTube channel and has been interviewed on 2 podcasts. She recently released a comprehensive fibromyalgia online educational course, which is available for purchase on her website on teachable.com. So there we go, Melissa. I'm going to hand it over to you here a little bit. Is there anything you would like to share before I start throwing questions at you?
Oh, no, I'm just really happy to be here. And I want to know from the audience, how many of you have treated or taught someone that you know has fibromyalgia? Or how many of you have fibromyalgia? Okay, all right. Okay, cool. Great. Well, it's very common. So that's good to know. Thank you.
Mm-hmm. Great. Okay. So usually the way that I have this go is I'm going to do a little interview here with Dr. Congdon. We have time for questions at the end, but if you have questions that are pressing before the end, you're welcome to stick them into the chat box. I'm going to do my very best to keep track of the chat as we go along here, and squeeze in those questions as we go along as they're appropriate. And if we don't get to them during the interview portion, we'll do our very best to get to them at the end of the talk as well, just leaving a little room for that at the end. So, all right, let's dig in. So first question is, can you explain a little bit, what is fibromyalgia and how is it recognizable? So what might a person or a client complain of who has fibromyalgia?
Yeah, it's a chronic pain syndrome of the muscles, tendons, and ligaments. There's no joint involvement early on, although a lot of us feel like our joints are involved. Everyone with fibromyalgia develops osteoarthritis later on, unless they're on a specific treatment we can talk about later. There's no generalized inflammation like there is in lupus or rheumatoid arthritis. It's not autoimmune, and all lab tests are normal, except we all have a low vitamin D or a low normal vitamin D. We don't know what causes it, although there's probably a strong genetic component. University of Cincinnati researchers have found an area on chromosome 17 that could code for the disorder. There is no blood test that is accurate and commercially available for fibromyalgia, but Ohio State University believes in the next 2 years they will have one that will be FDA approved, which is super exciting. It's really common. It's between 3 and 8% of the population. It's probably underdiagnosed, probably more like 10% of the population. The average time of diagnosis is about age 45, although the duration between the beginning of symptoms and diagnosis is between 5 to 7 years. Chronic widespread pain is the hallmark of the syndrome. Some people with fibromyalgia have more fatigue than pain, but almost all of us have non-restorative sleep. So it's chronic widespread pain, usually non-restorative sleep, fatigue, and cognitive symptoms, otherwise known as fibrofog. So it's recognizable by the chronic widespread pain. And the way it usually presents is that someone will have pain in one area, let's say commonly left shoulder pain. Maybe they can attribute it to playing tennis or some other type of injury or strain, and they might get physical therapy for it, and it just doesn't get any better. And then they develop pain in another area. So they had the left shoulder, and maybe then they develop pain in their right hip. No known injury there. And that's when a lot of people who are familiar with fibromyalgia are like, okay, this really now is widespread pain, and it's chronic, meaning it's lasting at least 4 months in 2 or more areas. So then you meet the diagnostic criteria.
Okay, awesome. And then, so orthopedic complaints, are there common ones, or are they just widespread or diverse in nature?
Most people with fibromyalgia will have neck and shoulder pain. Most of us have headaches, and most of us have hip pain. Yeah. So, and any kind of back pain, which opens up a whole can of worms, right? With back. Yeah. So it really can be any joint.
Okay. Okay. And so maybe, well, off script, but maybe we could be looking for people who are complaining of pain that doesn't relate to necessarily a specific injury, that's not really resolving. So it's kind of lingering, even though we've given our best effort. And then having some other unrelated, like a second area of unrelated pain that also doesn't make sense. So that might be something that would help us turn on a light bulb to become a little bit more concerned about, wait, maybe this isn't just maybe they didn't just injure their shoulder, or something like that. Sounds about right.
Yes, absolutely. And that is the perfect time that I teach physicians and people in your field too, Zaina, is to ask the important question is, when was the last time you woke up feeling rested? Because in my experience, chronic widespread pain lasting in more than one area for at least 4 months, and non-restorative sleep is fibromyalgia unless proven otherwise. It's 10% of the population. And so it's more than 10% of the people that you're probably going to be seeing. Mm-hmm. So if they're saying, yeah, boy, I used to wake up feeling rested, but in the past few whatever, I'm really am not. So that increases the chances that someone will have fibromyalgia.
Okay, great. Is there a common demographic, or who commonly gets fibromyalgia? You had mentioned 45 is sort of that mid-age. I don't know if you mentioned women more than men. I had that assumption, but I'll let you just clarify.
Sure. Fibromyalgia can occur at any age. Boys and girls can have fibromyalgia. And if it's diagnosed before puberty, it's 50% boys, 50% girls. If diagnosed after puberty, it's 75% women and 25% men, which is the same as all other chronic pain syndromes. Yeah. So the classic person that you will see is someone who's around age 45 and would be a woman. But it is the males with fibromyalgia that are often undiagnosed or diagnosed much, much later. And children with fibromyalgia also, it's most pediatricians don't really understand about pediatric or juvenile fibromyalgia, so they're missed also. So the kids, non-restorative sleep usually doesn't happen until around age 30. And so in children, it's harder to diagnose by using that special question that I told you, when did you last wake up feeling rested? But yes, in the classic 35-year-old or older, non-restorative sleep is a helpful question.
Okay. So could you tell us a little bit about what a day might look like for somebody with fibromyalgia after waking up not restored from their sleep?
Sure. Yeah.
Yeah.
Most people with fibromyalgia wake up really stiff. So stiff, more stiff than people with rheumatoid arthritis have in general. And in fact, some people describe at their worst having to crawl to the bathroom because they are just too stiff and in too much pain to walk. And heat really helps, and motion. A lot of people with fibromyalgia will take a warm hot shower in the morning and really start moving, and then the pain can kind of dissipate. Fibromyalgia is super variable symptom-wise. So you'll have people that really don't have much pain at all, and there are people who are bedbound from their pain. But generally we're stiff. And then as time goes on, especially in mid to late afternoon and evening, the typical fibromyalgia patient becomes super fatigued.
There is a question here, Melissa, that relates from Lane. So she's asking if does the pain cycle? Does it come on and stay on, or does it come and go? How would it look, or is there an average way that it might look?
That's a good question. It commonly cycles. People will have fibromyalgia flares where let's say we're talking about the left shoulder and the right hip, where it will be really bad for a while, maybe 2 to 3 weeks, and then calm down, and that might flare again. And so you might have various areas where you're having the right hip flare, but the left shoulder is feeling pretty good. But then other people, like me, for instance, my symptoms were head pain, so headaches, and right side neck and shoulder pain. And it was pretty much constant, but it's not unusual to have the flares in the cycles.
Thank you. Okay, so treatment options and what resources. I think, we're constantly, as somebody who works with clients, so whether physical therapy or Pilates, or parents or friends or family around, we're really kind of concerned with how can we actually help and not harm if we're in that helping industry. And I find for myself that it's always really challenging to find that balance and to get them the right information, get them the right treatment. I find that a lot of doctors don't, like you mentioned, don't really understand fibromyalgia. And obviously that is not my specialty. So the question would be here is, what can we tell clients if they come in and they say, I have fibromyalgia, or these symptoms don't add up, they don't know what it is there a conversation we can have around fibromyalgia, and maybe you can help us understand kind of what options does somebody actually have who does have fibromyalgia?
Absolutely. And just a little background, I was diagnosed with fibromyalgia by accident because my mom was suffering from some pretty severe chest wall pain. The intercostal muscles and ligaments were really, really sore, and she had new depression. And so my mom and dad asked me to go to a fibromyalgia specialist, and he diagnosed her with fibromyalgia. And then he turned to me and said, because I had a first degree relative with fibromyalgia, I was 8 times more likely than the general population to have it too. And he asked if he could examine me. And his exam, we can talk about this if we have time, was consistent and diagnostic of fibromyalgia. And then I went, oh, so I've been seeing a neurologist for head pain, and I've been seeing a gastroenterologist for GI pain, and all these other specialists, but if you put everything together, it's fibromyalgia. So, and he helped me get better. So I didn't have the experience of being, gaslighting or anything like that from specialists. But in my going on 12 years of experience seeing children and adults with fibromyalgia, it's very, very treatable. And the game changers I find in fibromyalgia recovery is eating foods that help you feel well. There are about 30% of people with fibromyalgia have blood sugar crashes when they eat certain types and certain amounts of carbohydrates. So a specific low carb diet can really help, and they can get pain and fatigue when they have the blood sugar crashes. So I use the generic term, eat foods that help you feel well. For me, I feel better off wheat. I don't need to be on a low carb diet. And getting consistent aerobic exercise is also vitally important, because people with fibromyalgia, if we do a biopsy of their thigh muscle, we find they have fewer mitochondria, and the mitochondria that they have are shriveled up. And after getting 6 weeks of consistent aerobic exercise, at least 20 minutes, 4 times a week, working up to that, that number and ability of the mitochondria to work increases dramatically. So I think my job here is to help you guys learn how you can help your clients with fibromyalgia be active. Yeah, because since most of us with fibromyalgia have experienced people in the medical field and out of the medical field saying, well, you look normal. Oh, why don't you just work harder? And we'll say to ourselves, gosh, that reformer class looks like so much fun. And we'll push ourselves too hard. So one of the things I want you to know is that in the fibromyalgia population, an abnormal amount of us are hypermobile. And this is something that as I'm examining people over time, probably in the past 5 years, I realized that when I was checking them for swollen muscles, tendons, and ligaments, I'm like, okay, got a little hypermobility there in the elbow joint. So I started doing the Beighton score, where you check for hypermobility. And I find that, about 25% of my patients are. So that's something that physical therapists and Pilates instructors should know, because you're going to adjust what you do if someone's hypermobile. And so I've talked about the fewer mitochondria. Also, studies show, and this is all in my online course, all of the studies I talk about, the links to them are on my online course. People with fibromyalgia have less collagen in their muscles. So the fewer mitochondria, increased chance of hypermobility, and the less collagen makes it very important for you guys to get a good baseline on what is your client's current status. How much can they handle exercise wise? Many of my patients would love to exercise, but they do too much too soon. And so what I say for Pilates instructors and physical therapists is add 20 to 30 years to your patient's age. If you're seeing someone who's 45, imagine they're 65 and 70, even though they don't look that age. And add that into what your initial evaluation shows you with their strength and their ability to, if they're hypermobile, and start ridiculously low and slow with them. Because, you know, it's much easier to build up than it is to have to wait until things calm down after an injury. So does that make sense?
Mm-hmm. Yeah, I think maybe I'll tell you a little bit about what I usually do, and you can say if you think that, or add to that, or say if you think it's worth correct or could be better. Usually, what is my biggest fear still in working with people who have fibromyalgia is that fibro flare or a flare up the next day, where they seem fine in the moment, and then the next day they come in and they're or they could send you a message and they say, I loved the workout while we did it. I can't get out of bed today. And it happens, especially in the initial phases when people, like you said, they want to get into that reformer class. I've had clients who have fibromyalgia, like, I think I can do the reformer class, and they feel good doing it and they just overdo it. And in that group setting, it's really hard to watch them. And then they come in the next day and they're like, yeah, I really overdid it last time. So what I ask a lot of my clients to do is actually journal, because something that I always tell all my staff and colleagues is that, you know, we get to see people for 1 hour a week or 2 hours a week, and then they're doing whatever else they're doing all the days of all the other hours of all the days. And so if we have good notes on what we're doing with the client, we can easily reference what we've done. But if they have notes on what else they've done that day, so maybe they come to you, then they go gardening, and then they have to pick up their 3-year-old from preschool, and there's the 3-year-old's sick in the afternoon and needs extra love and caring. And then we start to see the full picture of, okay, maybe it wasn't just what we did. Or they can say to you, the only thing I did was come to see you, and then I rested the rest of the day. Then you have the list of exactly what you've done. And hopefully that didn't flare them up. But if it did, at least you know. And what I usually do is cut it absolutely everything in half and start over if that's the case. But usually I'll keep that protocol. Once we develop that protocol that works, I only add one new thing the next time we see each other. Every time it's just one new, whether it's more repetitions or one new exercise, so that I can be absolutely sure that I'm not causing that flare up, and that we're still moving slowly, but we can tell if one thing flares them up, we know what that was. So that's classically what I tend to do. I don't know if you have any input or feedback on that, Melissa.
I think that's excellent. Do you have time to ask a client before a reformer class, what they're doing exercise-wise currently? So you know if it's someone who's just starting out, or if they are actually swimming or running, or, you know, doing whatever baseline.
Yeah, usually for us in our studios, we usually have an intake form. And so we can ask those questions, and hopefully if they're new, we get that intake form ahead and can do a quick scan through and ask the questions. Typically we try and take people who have special cases into privates first before we let them into the group classes, just because it's harder in that group class setting to actually even have enough time to discuss with them. But yeah, I think that's a great point, is that if we know where they are already and how much they can actually do, that will really help us understand how much we can do with them. Yeah.
Yeah, it's it's a major problem for physicians treating fibromyalgia patients because they won't feel better unless they get aerobic exercise. And you have to start so low and go so slow. And yeah, I do just what you do. I say, all right, find what you can do for 5 minutes. For me, I was so debilitated when I started fibromyalgia therapy. I could only walk on flat ground slowly for 10 minutes. And so I did that 4 times a week for a week. And then I added a minute, 11 minutes. And when you get up to 20 minutes, that's of consistent aerobic exercise, that's when you're making new mitochondria. So there's wide range, but most people with fibromyalgia who are not seeing you on an ongoing basis, they are not getting that 20 minutes 4 times a week. They are debilitated, and it's yeah, and so they need to start low and go slow. Yeah. And then it's awesome, right? Then once they're up to the 20 minutes of aerobic activity 4 times a week, then they just build on that, and the sky's the limit that way. But you just have to build up really slowly.
Great. And then I'm gonna, Lena, I see your question. I'll come back around to it. So treatment options or resources, obviously, you probably have a lot of things. Can we guide? The question I always get is, well, I'm not sure what, I've been diagnosed with fibromyalgia, but then they're kind of lost as to where do I go from here? My doctor sort of mentioned it, diagnosed it, and now I'm really not 100% sure what to do. So are there good directions we can steer them in? It sounds like, well, we could send them your way for you, even to your YouTube channel as well. But what could that discussion look like with somebody, do you think?
So the most important thing, and the thing that's really exciting for me being here, is that you are people who are really interested in supporting people with fibromyalgia. And the problem is that many people in the medical community, in fact, huge swaths of the medical community, and in fact, one entire medical group that's large in the Bay Area, doesn't believe fibromyalgia is a real condition. So they're not going to get support. They are told that they just need to relax. And in fact, in the Cleveland Clinic book on fibromyalgia and in the Mayo Clinic book, it talks, it's very depressing. It says there are lots of things you can try, but nothing really works. You can go on antidepressants and you can improve your sleep, but really just try to relax. And it's like, no, that is not comprehensive. So if your clients can find a physician in their health plan that has a lot of fibromyalgia patients, enjoys treating them, and gets good success, then that's awesome. Rheumatologists no longer treat people with fibromyalgia because it's not a rheumatologic illness. It doesn't involve the joints. So they threw it back to the primary care providers, who are totally overwhelmed. Integrative medicine doctors can do a pretty good job. So California Pacific has integrative health and healing. They're usually booked a year out, though. UCSF, although, yeah, I think that they're closed to patients too. But when they open up, that's an option. And yeah, I mean, that's why I started my practice. So what I find that there are other game changers. Proper hydration is super important. And studies show that people with fibromyalgia spend far too much time in the fight or flight response, where sympathetic, we are really more sympathetically activated. And doing specific exercises, and I have a whole module about this in my course, to help balance the nervous system, that can help a lot with how someone feels and can help them sleep better, which improves everything. And as you mentioned in the intro, the doctor that diagnosed my mom and me, he developed something called the guaifenesin protocol. Guaifenesin, the active ingredient in Mucinex, actually may get to one of the root causes of fibromyalgia, and it decreases our swollen muscles, tendons, and ligaments. And it was the most important factor in my recovery. So I offer that to patients as well. There are other medications. The one other medication other than guaifenesin, which has been found to be the most helpful in people with fibromyalgia, is low-dose naltrexone, LDN. The brains in people with fibromyalgia are swollen, and that causes pain, that causes fatigue, and LDN can decrease brain swelling. And then there are 3 FDA-approved medications for fibromyalgia: Lyrica, Cymbalta, and Savella. They work for about 25% of the population, and that wanes with time. But I do find that they do work in some of my patients, and that's wonderful. And so, yes, there are things that are available, and supplements too. Vitamin D can be very helpful. Magnesium can be awesome. So though, what I do is I put people on the 5 game changers, and I'm also checking to make sure that they don't have obstructive sleep apnea. Obstructive sleep apnea occurs in about 25% of the population. It's 45% of people with fibromyalgia, even without the risk factors of obesity or snoring. Every adult with fibromyalgia should have an overnight sleep study. And we have a higher risk of thyroid problems. So these are things that can make us tired and give us pain, right? So I'm checking for all of these things when I see a patient, because we need to separate out, okay, what are the symptoms from fibromyalgia, or what are symptoms from other things? Sorry, that was a long answer.
Thank you. That's a great answer. Yeah. Okay. So we kind of already touched on this one, but the best exercise protocol for someone with fibromyalgia, and how we can know and understand what the right amount of motion it is for a person with fibromyalgia. It sounds like we've already kind of covered this, especially that 20 minutes 4 times a week of aerobic exercise. My question, as we were talking earlier, shifted a little bit into, a lot of times Pilates can be anaerobic and less aerobic and more anaerobic. Based on what you've said so far, my gut feeling is now that I should really be focusing on more of that anaerobic initially, perhaps. Or are there any studies that show, you said the mitochondria aren't firing? Is strength training also a great option to get those mitochondria? And for those of you who don't know what the mitochondria are, I like to think of them as the cell powerhouses. So providing energy for the cells in order for them to be able to do their job. So our muscle strength is not there if the mitochondria are not. Do you have any thoughts or comment, or read any articles, or has there been any research on that at all at this point?
Yeah, you're right. Mitochondria make ATP, and that's our energy. But yeah, there's a joke in the fibromyalgia world that the best exercise for people with fibromyalgia is the exercise they will do, right? So it's if we tell somebody, okay, you need to walk for 20 minutes a day, they might hate walking. And so swimming is probably the best exercise for fibromyalgia, because it's not weight bearing. And also a reclining cycle is also very good, because the muscles are relaxed. And for some people, a rowing machine is good. So something like that, where I mean, there are a lot of pools in this area. I swim at the Tam pool, and it's not expensive, and it's really nice, and there are hot showers at the end. It's really great. So, if you could encourage your clients in between sessions with you, if they could be doing something like swimming or just movement in the water or some type of stationary bike or something like that, where they are really building their muscles, then that's going to make them more able to take a reformer class and not crash afterwards. So it's kind of like you got to meet them where they are and find out what they like exercise wise, and see if they can do a little bit of that, and they can mix it up 4 times a week, and then you've really got them on the path where they're building strength, they're building muscle tone and strength, and they're going to be more able to do the things they want to.
Great. And then I'll just add to that. So say that we work with somebody, or they say that I'm having a flare, or I just had a flare. Is there a way that, is there an amount of time we should wait? If they're flared, my guess is we let them rest till they're not flared. Is there a time period that those flares usually last, or a time period where we should keep them resting before we try again to get it right, or they try again to get it right? Or is it just when they feel better, then they can start again?
It's when they feel better. And it can vary from person to person. It can be vary from time to time. But oftentimes someone will say, my typical flare lasts 10 days to 2 weeks. And then you can ask them if there's anything that they do to help make their flare not so bad. I find that Epsom salts baths are one of the things that helps the most. Again, that's magnesium, and at least 2 cups in a warm bath in the evening or anytime during the day is helpful. You can increase that amount of Epsom salts up to bowel tolerance, as they say, because even 4 cups or more are fine. But if they start to have loose stools, then they're absorbing too much magnesium. And so some people take baths a couple times a day, or hot showers, but then you have to use magnesium oil. But you can do that. They're over-the-counter magnesium sprays that can be put on muscles, and that is my patient's favorite way to decrease the severity of flares. And sometimes Tylenol, and especially Advil, can help too. But yeah, I love the Epsom salt treatment.
Okay, awesome. And so if a flare lasts 10 to 14 days, then they really should be resting those 10 to 14 days and then restarting after that.
Yeah, and some gentle movement, gentle stretching.
Okay.
Overstretching is a problem, and that will cause stiffness and soreness. So gentle movement rather than stretching is a good idea. And one of, I think, the best positions to be in to really help the muscles relax and stretch a little bit is have them go in the fetal position. Just grab both legs. That relaxes the psoas muscle. It's stretching the shoulders and arms and some of the legs, and they can do that lying down, or they can do that sitting up, and just gentle activity. Yeah.
Perfect. Okay. Let's see. So last question that I have here scheduled, and then we'll go through everybody else's questions, is what can the outcome be for someone with fibromyalgia? And you've already mentioned a little bit about this, but maybe you can elaborate as to what could be somebody's expectation who has fibromyalgia.
So when I see a patient, I fully expect that they're going to feel better over time. Again, for me, I'm ruling out obstructive sleep apnea or making sure it gets treated. I am making sure if they have thyroid issues, that's being treated. If they have a low vitamin D, they're supplementing, that kind of thing. But the 5 game changers with eating foods that help you feel well, getting consistent aerobic exercise, guaifenesin protocol that really gets to one of the underlying causes, proper hydration and mind-body therapies, those 5 things, it really works well. And so I find that most of my patients feel better over time. That if someone does have what we call carbohydrate intolerance and they're having blood sugar crashes, and they go on the low carb diet that Dr. Sadaman came up with, the foods that you can eat that don't cause blood sugar crashes. Luckily, that's a long list of foods. They feel better in 2 weeks, 2 to 3 weeks. It's crazy. So, but that's not fibromyalgia. That's the symptoms caused from crashes. Fibromyalgia takes 9 months to a year for people to really feel better, to really get their muscles strong and address their pain. And that's where LDN can be helpful, or some of the other medications. LDN can reduce pain and improve sleep. And that has been a very, very helpful medication for my patients early on, until the other treatments that I'm giving them really start to kick in by 9 months a year.
So we should encourage them to keep going. But
Absolutely.
it's going to be a process, right? Yeah, over time. And then this wasn't in here at all, but I've heard that the time, and you and I discussed years ago, that the time that you've had fibromyalgia also has something to do with how long it takes you to recover from fibromyalgia. Is that accurate, or?
Yeah, absolutely. And this is specifically for the guaifenesin protocol, but yeah,
Okay.
If you have had, you get better with fibromyalgia. If you've had it for a short period of time, you get better faster. And so this is where it's important to really get their history. There are a number of adults that I talk to that have had pain since they were very young. And some of my patients have even had issues since infancy. And so obviously those are going to be the people that are going to take longer to feel better, because they have more issues with their muscles, tendons, and ligaments. But yeah, if you get them on the right program where you are doing physical therapy that's really increasing their mobility, decreasing pain, and you're helping them with in a Pilates class that is really strengthening their muscles and strengthening their core, that's going to really speed their recovery.
Great. So I'm going to open up for questions, Lane. I didn't get to your question. I will ask it now and then let you elaborate if you like. So here's another question. Is there currently any measurable change in the morphology or nerve conduction within somebody who has fibromyalgia?
Nerve conduction. Oh, so you mean firing? Yeah. No. Nerve conduction studies are normal.
Great.
And then on that, I was a biochemist, so I'm looking for something more fundamentally, universally triggering. Are they working on anything that underlies the various symptoms, including the collagen, the guaifenesin? Those are, like, to me, that's, there's a little connection there. Why would that be that way? So are they working on that particular zone? Do you know?
So if you take a look at the FDA funding for fibromyalgia studies, it's minuscule, because why would they want to spend money on an illness of neurotic women that really doesn't exist? So the money is really spent by the drug companies, like, Cymbalta, Lyrica, and Savella, that are really masking the symptoms. so that's super frustrating for those of us with fibromyalgia. I'm so happy that Ohio State is, putting their money into research for a test at least. Once there's an FDA approved blood test where someone is diagnosed with fibromyalgia, then I think that the attitude of doctors in certain, health management organizations are going to change. But yes, that's the reason that I like the guaifenesin protocol, is that my mentor, Dr. Paul St. Amand, found that people with fibromyalgia, their kidneys are sluggish in excreting phosphate. Their kidney functions normal, but with guaifenesin, they're able to excrete phosphate in the urine 6 times greater. So this is at least one of the underlying causes of fibromyalgia. We know it's genetic. It's such a strong, I take care of grandmother, mother, son, cousins, all from the same family. And I see this over and over. So there definitely is a genetic component, and it might be on chromosome 17 for one family and chromosome 7 for another. But the success that I've had, and my mother and daughter have had on the GUI protocol, and so many of my patients, that yes, there are physiologic issues, and it's going to be a fantastic day when we know more about that, because then we'll be able to give targeted treatments rather than masking. But until that happens, we have guaifenesin, and for that, I'm very grateful. Yeah.
Okay. Any other questions? If you guys have questions, feel free. You can unmute yourself and ask a question. Yeah, go ahead, Linda.
Doctor, I'm actually calling for my daughter. I don't have fibromyalgia, but my daughter's had it for over 15 years, and she's 41 years old and has been in pain all this time, being diagnosed with rheumatoid arthritis, Ehlers-Danlos. We could go on forever, but nobody treats her. Everyone just says, go home and pray, kind of thing. Yeah. And even the pain management doctors, they just give her more and more drugs. And then when she can't stand the pain, then they think she's just looking for more drugs. Yeah. So I'm looking to try and support her and help her. We live here in Marin County, so I noticed your practice is here, but when I looked up your name, it said you're not taking patients right now, which disappointed me. But yeah. So I'm looking to help her find someone that can help her live a normal life, because it's devastating to watch her child in pain.
Yes, and I'm so sorry to hear that. Unfortunately, that is far too common. There is a doctor in Colorado Springs who does virtual appointments. I trained her. Her name is Dr. Meg McDonald. Just Google Meg McDonald, Colorado Springs. And yeah, she's excellent. And she's who I would recommend first and foremost. There is a doctor at UCSF, but she's booked over a year out. I don't even know if she's taking new patients. And Dr. McDonald has more flexibility. And your daughter might, and you might want to check out my online course. Because it's a video course, which is nice for people with fibromyalgia because they don't have to read anything. Where I talk about what is fibromyalgia, how is it diagnosed, how do we know it's real, what are the treatment options, all of these things are discussed in the hour course, and people who watch it say that it really gives them a good starting point to decide, okay, well, I'm going to ask my doctor about LDN, or I want to get started on the GUI protocol. Oh, here are these resources. Here are these support groups that can help me get started. So you might want to check that out as a way for you or her to get started. So Dr. McDonald and my online course is what I'd recommend. And hopefully I will be accepting new patients soon.
Do you have an estimated time frame for that?
No,
No.
I don't. So,
Okay. Okay, fair
but
enough.
you can contact my receptionist and get on the waiting list.
Okay, thank you.
You're welcome. Other questions? And feel free to, if any of you have fibromyalgia patients, feel free to direct them to my website where they, and that has links to my YouTube channel where there are free videos, about fibromyalgia, educational videos, and links to the online course. Yeah, there is hope for everybody with fibromyalgia to feel better. Yeah.
I've one more question.
Sure.
If you have a client that seems to get some pain during or right after a workout, and that is short term rather than a flare that's like 10 days to 2 weeks, is that not a typical fibromyalgia symptom?
Correct. Yeah. And if they feel fine the next day, then I don't, yeah, that's not a fibromyalgia kind of thing. It seems to me it's more like a muscle weakness kind of thing. Yeah. Yeah. So you can work on strengthening their muscles, and hopefully that symptom will be less and less.
I can't hear you. Yeah, go. Maybe you're muted. Or if you like, you could write in the chat and I can ask for you. If
Hear me now?
yes, we can hear you now.
Have you found that PRP is in any way helpful in the joint areas, Dr. Congdon?
It can be. I have some patients who have found it helpful. An equal number have not found it helpful.
Okay.
So it's one of those things that yes, can be worth a try. Absolutely.
Thank you.
Sure.
Yeah. I wanted to pull in two things if I can. We've recently just had a whole series on menopause with Dr. Ricky Polikoff in San Francisco. I don't know if you're familiar with her.
She's
Yeah, lovely. Yeah. And the other doctor, we've also had a talk on Ehlers-Danlos and hypermobility. Very much I'm passionate about both those things myself, which is probably why we've had talks on all of these things. But what links are there, if there are any, between women going through menopause and fibroflaring or fibromyalgia diagnosis? And then on top of that, if there's more connection, you already mentioned there's a connection between the fibromyalgia and hypermobility or Ehlers-Danlos. Maybe you could elaborate just a minute and tell us what you know about those connections.
Sure. So what we find in fibromyalgia is some people develop symptoms slowly over time, and that's the way I develop symptoms slowly over time. The other half develop symptoms suddenly after some kind of stress, whether that's a car accident, death of a loved one, birth of a child, or menopause, because that can be a stress on the body. So yes, any type of stress can flip the switch and cause fibromyalgia to bloom and become symptomatic. Now, Ehlers-Danlos is something that I've become more interested in over time as I've noticed the hypermobility piece. And now I think I have 3 patients who just received an EDS diagnosis. And, I've been really floored as to how many things other than pain are part of EDS, right? And so this is where I think we need to get the input from the various specialists when we treat our patients. And I currently take care of a mom and daughter who have recently been diagnosed with EDS, and the daughter's very symptomatic. So I have meetings with her various specialists. So we we talk about, okay, what do, from our specific vantage point, what do we think would be helpful here? So I think with EDS, where it is really involves a lot of the body systems, that collaboration is really important. Yeah. What do you think, Zaina?
Yeah, I mean, EDS really, I mean, you mentioned affecting the fibromyalgia. People who have fibromyalgia, also their collagen is affected. We're really looking at collagen, ligaments, tendon, like all those soft tissues just not doing their job, not able to support the skin in clients, the internal organs not being able to function in the severe cases or the long-term EDS cases. So they seem to have some overlap. Plus then if you layer on top of EDS, all of those things in a more chronic situation, you're looking at fatigue, difficulty with exercise. So a lot of the symptoms then start to really overlap with those of fibromyalgia. And so it's just an interesting connection there. And EDS being difficult to diagnose, finding doctors who actually will diagnose it. And people coming to me all the time telling me that everybody's thought they're crazy. And I'm the first person that'll sit down with them and talk to them about it and say, well, actually, you're not crazy. And the fact that you feel like your head's going to fall off when you go over a bump in the road is not crazy, you know? So, yeah, I find it super interesting. I'd love to see some studies, you know, kind of cross referencing with the EDS and the fibromyalgia and see what's there. And then a lot of clients, it starts, like you said, starts with pain in the shoulder, and then it's pain in the elbow, and then it's pain in the wrist. And then we're looking at, like, from a physical therapy standpoint, I'm then looking at, is it the shoulder causing the elbow pain? Is the elbow pain causing the wrist pain? Is it a thoracic outlet issue? And where does it start and end? And if it's Ehlers-Danlos or hypermobility, then it's that more, or collagen issues. So that's a lot to not really answer your question, but
yes, thank you. And so what? Yeah, when I started out in fibromyalgia consulting in 2010, I thought, oh, this would be easy. You know, just see people with fibromyalgia and put them on guaifenesin. Yeah, great. Some of them need the food plan, but you know, as we see more and more people, we learn more and more. My mentor taught me how to diagnose fibromyalgia by physical exam, because he found that everybody with fibromyalgia has a pattern of small swellings in their muscles, tendons, and ligaments throughout their body. And if they have these small swellings in their left anterior thigh, and in the left anterior thigh, they're small swellings, they do not hurt, it's diagnostic of the syndrome. So that's an advantage I have. And I taught Dr. McDonald how do we call that? We call that mapping. So I have seen a number of EDS patients who will call my receptionist and then will email me and say, hey, my doctor thinks that I have EDS and fibromyalgia, and I will see them for free to do the quick mapping exam. And most of them don't have fibromyalgia. So then they know that they can really focus on the EDS. And I do have patients that have both. So the bottom line is try to find out what conditions your client has.
right.
They have EDS, do they have fibromyalgia? Do they have obstructive sleep apnea? Do they have hypothyroid? Do they have low vitamin D level? You know, these kind of things. So there's the barrel theory. First, you find out what conditions are in the barrel, because when the barrel is filled and overflowing, symptoms occur. But if you can decrease the amount of water in the barrel, it doesn't overflow and you're not symptomatic. So find out what conditions are in the barrel. Then you can address each one, or you can refer them to someone who addresses. And then you're going to really make progress with a patient. Yeah. So this gets complicated. In my world, most of my patients are not this complicated. They have fibromyalgia, might have some obstructive sleep apnea, maybe a little bit of hypermobility, but that's it. And so with the basics, they get better. And then for other people who are more complicated, then we have to do more testing. But yeah, I find that yes, once you know what a client has, then you can address it and really treat that. And again, then you're more likely to have a patient really start to feel improvement.